So the three bispecifics we're going to talk about are ivonescimab, again, the subject of Harmony 6 plenary session today, pumitamig, which I've already referenced, and then we still got a number here, PF 086344404. And they're all very similar in conception. So starting with pumitamig in small cell lung cancer, this was a trial that read out in the last year or two. This was looking at pumitamig plus chemotherapy in the first line, extensive stage small cell, and essentially establishing this as a very active approach. You can see, based on dose, a objective response rate between 66 and 85%, and nice durability to that. This is going to be further evaluated in the Rosetta Lung 01 study, and I think is very exciting, and we will see how that plays out. Additionally, pumitamig monotherapy in non-small cell lung cancer looks impressive in both non-squamous and squamous disease, and we can see the durability of this with a prolonged PFS and OS curve. The Rosetta Lung 202 study is, I think, a very good design. It's looking in these PD-L1 high patients greater than 50%. And it's basically randomizing patients to receive this bispecific antibody versus pembrolizumab, and that will give us a clear look in what I do think is the right standard of care comparator arm for our PD-L1 high patients to see if adding this bispecific and this VEGF or anti-angiogenesis MOA can improve outcomes for these patients. Now, I referenced this trial earlier, and it's a trial that I'm very excited about, the BNT32401 trial. You can see the NCT number here. But this is combining the B7-H3 ADC BNT324 we talked about earlier, plus the bispecific pumitamig. And essentially, we're three different mechanisms of action, with the topoisomerase 1 payload being delivered by the B7-H3 ADC, and then the bispecific immunotherapy and anti-angiogenesis. You can see all of the different concepts in terms of how this can be beneficial for our patients, and ultimately, again, looking across both non-small cell lung cancer and small cell lung cancer in terms of benefit. So we've got a trial of interest here. This is looking at pumitamig. This is the Rosetta Lung 02 trial. This is looking at patients receiving pumitamig plus chemotherapy in frontline non-small cell lung cancer. This was presented at this meeting. I like this slide because it shows some preclinical data to support some of the MOAs that I've already discussed in this section. You can see VEGF-A neutralization at the top left hand of the slide based on the bispecific, as well as immunotherapy and PD-1, PD-L1 engagement. On the top right, you can see that complexes are being formed with VEGF-A, which will lead to clustering colocalization with PD-L1, and that these complexes are then internalized, which is different than our PD-L1 monospecific antibodies. So I think it's going to be really critical as we continue to develop these drugs, as I mentioned early on in the presentation, to be understanding the science as best as we can so that we can help identify patient selection and potential additional biomarkers for these drugs beyond what we have with PD-L1. So in terms of the trial design, it's pretty busy, but we're looking both at non-squamous and squamous on this trial, this bispecific antibody in combination with chemotherapy. You can see in the 44 patients here, pretty even distribution between non-squamous and squamous. And importantly, the vast majority of patients enrolled here are going to be the patients that need this type of a therapy the most, and that's the patients that are PD-L1 negative. Again, having this, if you were to have this trial in clinic, those would be the patients you'd want to enroll, and that's in direct contrast to potentially the PD-L1 high patients where chemotherapy may not be as important for those patients. So I think that, based on this data set, these patients weren't selected for, but we're actually getting a readout on the patient population that I think is most in need of this approach. And the data is looking very good, but we'll get there. So in terms of toxicity, toxicity profile looks good. These are, many of the toxicities we would anticipate with a VEGF component to our therapy, so hypertension, proteinuria. But overall, I think that the toxicity profile looks good here. And then in terms of activity, looking very strong in both the non-squamous and squamous population. I think that one of our questions, pre-test questions, I'll just call it out, was like which patient populations had greater than 60% response rate. You can see in the non-squamous as well as the squamous, and then you'll see here in the high PD-L1 high and the 1 to 49, we're seeing greater than 60% response rate. In addition, the PD-L1 negative patients, these are patients you would not anticipate to get benefit from immunotherapy, but we're seeing a response rate around 50%. So it's still very active in those patients, and I would argue those are the patients that need an approach like this the most. And when we're seeing responses, of course, what we're really trying to achieve in our patients, and specifically with the immunotherapy aspect to this, we're looking for durability, and that's what we're seeing with the spider plots. So in conclusion, certainly encouraging efficacy across PD-L1, the spectrum of PD-L1. I didn't call it out because it's not overly surprising, but in the high PD-L1 patients, I think it was just a handful of patients, we saw a response rate of 100%, manageable safety, and durability. So we'll see how this plays out in bigger patient populations and in a randomized nature. Moving back to ivonescimab, and we will get to Harmony-6 shortly. This is an approach that's approved in China. It's a combination of ivonescimab plus chemotherapy, and this was a topic of a lot of discussion, I think, several months ago in the context of the World Lung presentation when the Western cohort was included in this analysis. The overall survival benefit looked to not be as impressive as what we saw in the China data. Certainly there is a BLA that's been submitted. We'll see if this is an approach that gets approved for our EGFR patients. But certainly there's a lot of historical data to support the idea that immunotherapy is not beneficial in EGFR patients, and there's a lot of historical data to support the idea that anti-angiogenesis approaches can be beneficial in our EGFR patients. So what happens when we give them together? We will see how that plays out in terms of the regulatory filing. Okay, so Harmony-6, I suspect many of you were at the plenary today, but for those of you who are not, this is obviously an important data set to go over. This design was very appropriate in our patients. Again, this is a China-only population, but these are patients with squamous disease. They were randomized 1-to-1 to receive ivonescimab, the bispecific antibody plus chemotherapy versus an anti-PD-Agent plus chemotherapy. And the primary endpoint here was PFS with a key secondary endpoint of overall survival. Baseline characteristics are key here. You can see a lot of patients with PD-L1 negative, which is good. Again, those are the patients that need this therapy the most. There was a lot of confusion, I think, around the tumor characteristics because patients with invasion of the blood vessels, cavitation, or hemoptysis were excluded, but then they were included here. And I think it's a bit confusing. We're also working with a lot of these agents on clinical trials, and I would argue that the inclusion-exclusion have been very stringent with respect to these criteria, and I think that Dr. Bramer's comments today were very on point, and we'll highlight them also in a couple minutes, that we really need to be developing our drugs in a manner that's consistent with the patient population we're treating, and we can do this in kind of a clean room and make sure we're excluding any patients that could potentially have any level of toxicity, but then are we really developing drugs in a way that we're going to be treating our patients, and what do we do for the actual patients in front of us? So I think this is an area to continue to discuss. I think the other thing that Julie highlighted, it's not called out here specifically, but we will look at, was the fact that the trial itself had a blanket exclusion for patients greater than 75. I don't know about medical or scientific justification of that. I would take significant issue with that. And there's some concerning things on the forest plot to suggest that the older patients maybe didn't get the same benefit, which we'll highlight. But certainly a positive trial, and critically important. In the patient population, with all the caveats that I said, it's a Chinese-only population. It's a patient population where certain patients that are pretty standard in terms of hemoptysis, cavitation, and blood vessel involvement were excluded. All of those things aside, clearly this approach was superior to the standard. You can see the hazard ratio of 0.66, and the p-value is significant, although, as Julie also highlighted, the median follow-up here is very short, so you see a lot of tick marks and a lot of censoring, so we'll see how this plays out over time. Subgroup analyses, the one thing to really pull out here is the fact that the greater than 65 patients, which most of our patients with lung cancer are greater than 65, maybe really aren't getting the benefit from this novel approach, so something to keep an eye on. When you look at it based on PD-L1 expression levels, it looks like the benefit of this approach persists in the negatives, and the positives persists in the 1 to 49s and the greater than 50%. And in terms of safety, certainly with the addition of the anti-angiogenesis component, you are seeing more toxicity, maybe a trend in the serious TRAEs to be watching, but in general appears to be tolerable. In terms of the TRAEs specifically, the only thing to really call out here is the proteinuria difference, where we're seeing a much higher level with the anti-angiogenesis component. The rest of this looks pretty similar on this tornado plot. And in terms of the potential VEGF-related events, they're listed here. Not surprising, but I don't think any of these are prohibitive to administration of this therapy. So the conclusions here were clearly this met its primary endpoint. This does establish a new standard of care in the patient population it was evaluated in, and certainly looks very promising in terms of the hypotheses, even beyond that patient population.